Okay.
Adriana.
Hello, everyone. So great to see you. We're going to get started in a couple minutes. So please get your food, get your friends, and get ready. Hello, everyone. How are you doing? Hello, everyone. How are you doing? Great to see you all. Thank you so much for coming to our lunch symposium, Collective Empowerment, Making the Best Choice. To get started, I would first like to acknowledge the land that we are on and acknowledge it profoundly because I've been here since Tuesday, and this is my first time in Halifax and in Nova Scotia, and how beautiful is it? But I think that as settlers and as an immigrant woman myself, just honoring this land and understanding the history of Indigenous peoples on this land and the history that they have continued. Halifax is a vast history, and I encourage you all to explore it throughout while you are here. And I want to acknowledge the Mi'kmaq territory and the Pescataway territory and the Wolastoqey territories. These nations hold inherent rights to the original peoples of these lands, and we are all guests here, and how lucky and grateful are we to be here. And as we think about the work that we are doing here and the work that we do to dismantle HIV stigma or encourage testing, encourage prevention and treatment, I think also we can look to Indigenous peoples and also just get inspiration from the years of work that they have done for the rights of their people and their lands, and also thank them for letting us not only live and work, but love and enjoy each other on this land. So I implore all of you to explore Halifax and explore the history and how it connects to you. And we all are so grateful to be here today with you. And thank you also for coming. So to get started, we would love to hear from you today, so please engage with us throughout the program. Questions, short answer questions, will appear. There's also a space for you to submit questions. You can scan the QR code on screen or at your tables to access the Slido. Go to slido.com and enter the code, or again, you can scan the QR code that is on the screen right now, and you can also find it on your tables. We would love to hear from you throughout this session. This is our disclaimer and our disclosures. I would like to introduce myself. I'll be your moderator today. My name is Muluba Habanyama. I wear many hats in the HIV sector with the Ontario AIDS Network, the Canadian Foundation for AIDS Research, and the CAHR Pan-Canadian Network for HIV and STBBI Clinical Trials Research. Isn't that still a long name? We're still getting used to it. But first and foremost, on this stage and in life, I'm a Black woman living with HIV, and that is how I first come into the world. I'm going to start and ask my panelists to introduce themselves.
Okay, I'm Jonathan Angel. I'm an infectious disease specialist and HIV physician from Ottawa. That's it.
I'm Heidi Farron-Joven. I am a nurse practitioner living and working on Treaty 1, Winnipeg, Manitoba. I work at 9 Circles Community Health Center, as well as do virtual HIV prevention with Freddie, pardon me.
Hi, everyone. My name is Khaled Salam. I use the pronouns he, him, and I'm the executive director at the AIDS Committee of Ottawa. Thank you.
My name is Andrew Brinuyan. I work as a family physician in Montreal in a sexual health clinic and in rural hospital work. And I work also at the federal level in a women's prison in Quebec. And I'm happy to be here with you.
Awesome. These are our disclosures, and I would also like to take the time to thank ViiV Healthcare for your support in the symposium. So let's talk about today in this session. Our objectives are to discuss the importance of prioritizing choice to empower people to make informed decisions in treatment and prevention. Also to describe the transformative role of long-acting options on personalized choice in treatment and prevention. And our last objective is to identify potential barriers and solutions to make informed decision-making from the personal to systematic level in treatment and prevention. So let's look through our eyes and have a little reflection activity. One of the things that also is my role is I'm a big yogi, and I'm also in the beginner training to become a yoga teacher. So I'm happy to now test with all of you my little meditation voice, because I've been known to be loud. So we're going to find calm Muluba if she exists. So please close your eyes, take a deep breath, and picture a nurse. Continue to close your eyes, take another deep breath, and picture someone living with HIV. Take another deep breath and picture a researcher. Another deep breath and picture a doctor. And another deep breath and picture a pharmacist. We all know that each image could be completely different than what we pictured, but we still picture a particular image. That's just our bias. This is implicit bias, which is totally normal, in fact. Implicit bias doesn't actually define us, and nor is it our fault, but it can have an unconscious impact on our choices, decisions, and actions. Now let's reflect on ourselves. Think about what are some core beliefs that truly define me, and how does my work, profession, or what I study shape my core beliefs, and how do you think it might shape your daily interactions and decisions, even when you think about the last few days? We all have implicit bias, and acknowledging it is an important way to prevent it from having an impact on our actions and our work. By acknowledging it, we can identify it when it happens and tweak our thinking to challenge the bias. So let's get real. Today we will discuss decision-making and choice in HIV treatment and prevention from many different angles, but we want to approach it with intention and to get real. Each of us will work to challenge our own biases for those we might see around us. I'm going to pass it on to
Yeah, thanks. Thank you very much, Muluba. I think I have control, but little control. The WHO makes recommendations on service delivery for treatment and care of people living with HIV. Notably, HIV programs should provide people-centered care that is focused and organized around the health needs, preferences, and expectations of people and communities. Our programs should engage and support people and families to play an active role in their own care through informed decision-making. So how can we do this? So let's look at recent congresses to kind of recognize how this has been identified. Key themes have emerged at recent congresses, one of which is the importance of choice. Choice and person-centric approaches are taking center stage, be it in the overall Congress themes, dedicated work streams, or plenary sessions. In the HIV R4P conference report put forth by the IAS, another important point is that preferences evolve over time, so accessibility, flexibility, and empowerment are critical, and that's reflected by our own conference that you're at today. We've also seen, I think I read that. We've also seen that long-acting options become major points of discussion, given that many new options and research is expanding this approach. This brings to light how all options, long-acting and daily oral options, are important aspects of choice when we are talking about options. Back to you.
Thank you so much, Dr. Angel. Thank you for that reflection. With all this talk and talking about through the eyes of the healthcare provider and the importance of choice and shared decision-making, we want to do our best to share the spotlight a little bit. Throughout this question, we'll ask discussion questions to our panelists and to you, our audience. So please, again, submit your open text response to the same question within Slido. So our first scenario is a patient client is doing well on their current oral regimen. During a follow-up visit to their healthcare provider does not present a different or newer treatment option. What are some considerations when presenting options to patients and clients, and what are some barriers to presenting all options? And these barriers can be individual or systematic.
So would you like me to start, Mo?
Yes,
with my thoughts?
Yes, please.
Reflecting on what you said, have said, Muluba, on biases. Every physician has their own biases, their own thoughts, their own approach to managing their clients or their patients, and also patients are also varied in their expectations. And then there's the relationship between the two, the physician and the patient, and that's all varied. So going back to the question, or the point of options not being raised, the context is not uncommon. Someone comes into their physician for HIV care, the physician says, "How are you?" and they say, "Fine." There's really little incentive on the physician's side to engage further. When someone says they're fine, we tend to take their word for it. It may be the case, it may not be the case, but that's what we tend, and that's the easiest to do. So it's the idea of raising options beyond what a person is taking or future therapies takes time, it takes energy, it takes knowledge, it takes familiarity, and different physicians will manage that differently. I think some physicians will take this opportunity. Maybe they have time to discuss current options, future options. Maybe others are stretched for time or have little time, and if a patient says to them, "I'm fine," there's zero incentive to go beyond that. So I think there's a lot of things that dictate how that relationship or how that interaction works. And there's not one way, there's not one approach. And I think what's important within this is the expectations the physicians have, which are varied, and the expectation the patients have, which are varied. And I think, just to summarize, I think it's important for patients to be able to advocate for themselves, whether it's to say, "I would like this," or "I want you to make the decision," right? So they can advocate for yourself in lots of ways, but I think that's important. I think physicians in general are very open to that approach, and we probably would want to see more of it.
Yes, thank you. And that's interesting. Martin and Colette, what are your thoughts? And Dr. Andrew, you mentioned maybe there's not an incentive in mentioning. I'm seeing some comments from the Slido where people think it may be laziness, or is it bias from the healthcare provider? What about the cost of the medication? Different considerations about how long the patient has been on their current therapy. So what is your perspective?
So all of the above, obviously, Muluba. But yeah, thank you, Jonathan, for sharing your perspective. I think, we started this particular section talking about, how the oral medications are going well, for that particular person. So I think when you say the oral medications are working well, going well, you're really looking at it, from a numbers perspective in terms of their CD4 count and viral load. So obviously, yes, everything looks good on paper, but perhaps it's not the best option for them if you look at the overall person and if you look at it from a holistic point of view, like what is happening, what are their family dynamics like, what is their lifestyle like, are they, do they travel a lot, are they disclosed to their family, do they have disclosure challenges and barriers? So there's many different things that if you were to look at, it might inspire a healthcare provider to offer different treatment options and not, if you're not just looking at it purely from, like I said, somebody's CD4 count or somebody's viral load. And the barrier for obviously healthcare providers is time, and you're not able to spend a lot of time, to really be able to flush out, everything that's happening in somebody's life. So I think that's where other, like the multidisciplinary approach, having, social workers, psychologists, community-based organizations like where I work, be able to work together to be able to get the whole picture so the healthcare provider can then offer the best treatment options. And then from the patient perspective, I think, when someone like Jonathan, says something, it's gold, right? He's a doctor, he's pedestalized, and I can say this because I actually have a lot of respect for Jonathan and we have a great relationship, but doctors in our society are pedestalized, and that's, that's the truth, right? Even when I go to see a healthcare provider, sometimes, depending on what they say, I just automatically, subconsciously assume that is the best option for me because that's how we're raised in society. So I think that piece is also difficult from a patient perspective to be able to tell their doctor, I heard about this option, this particular injectable, and maybe, that's better for my overall lifestyle. But people, don't communicate with their healthcare providers because of the pedestalizing that happens.
I
I'll
think that's
stop
the
there.
balance, right? And Jonathan, you mentioned patients being able to advocate for themselves, but we look sometimes at healthcare providers as authority figures. And somebody who grew up living with HIV, I looked at my healthcare provider as my mom would say, you know, you respect them. They're like similar to an authority figure, a teacher, a cop, or an aunt and uncle. So you just think, okay, what they say goes, and not realizing, no, this is actually something, a balancing act. Heidi, I'm seeing a comment about different fears, different objectives. The patient has different objectives maybe than the healthcare provider. What are your thoughts?
Yeah, thank you so much. And I definitely agree, Khalid, to elaborate on what you mentioned and kind of to comment on patriarchal medical models, right? We've been rooted in these models for forever, and certainly no knock, and I have the utmost respect for all physicians and everyone in healthcare, you know, regardless of the hat that you're wearing. But I think our clients are really fearful of asking these questions. Again, as you mentioned, oh, the doctor knows best. What the doctor says is what I'll do. But you know, really empowering our clients to question the norm, to educate our clients and to bring that awareness to them so that it really is fostering a client-provider relationship. And so, you know, in terms of fears, it's creating that safe space for clients to ask those questions, and probing deeper on the everything is fine. What does fine mean? You know, fine usually is, there's usually a but. And if we don't take that opportunity to kind of explore deeper, then we may miss some symptoms that the client is experiencing or some questions that they may have. But again, they're just too intimidated or fearful to ask and to question, again, people in a position of power.
Andrew, what are your thoughts? There's also that what's that saying or that model of if it's not broke, don't fix it, right? So if this is something that's working, let's not talk about it. Your thoughts?
Yeah, well, thank you. I just want to piggyback on Heidi saying that it's important to question the norm. I think even as providers, we're scared to question the norm. And coming from a place of perhaps lesser years of experience than some of my colleagues here, sometimes we come into it like late tardily, and we question ourselves and our knowledge, our ability to provide these treatments. And there's a lot of science that's constantly evolving at a pace that we have difficulty catching up to. And sometimes we're just, okay, it's working fine. We're not going to change the formula, and we're not even going to bring it up, even though I know there's this new thing I've heard in the back burner that came up and seems to be, you know, very positive for patients. So that own insecurity, and I think needs to be sometimes looked at and observed, and us ourselves should be questioning the norm of what we know of our current state of things. And if we're unable to do that, how can we expect our patients to have this discussion with us if we're in that insecure way? And unknowingly, we create this gatekeeping sense when we disclose some of the information that might benefit our patients. So this is my stance. And I know a lot of clients or patients that I've seen who were on their meds for years and are doing well, undetectable, seems to be tolerating it well. And then at some point, we reached a point where we were like, okay, let's try this new medication. And then some of the symptoms that they were experiencing for years, insomnia, neuropsychiatric symptoms, resolve. And you're like, why didn't I do this sooner? And that, I think, because I didn't even question what the impact of, you know, my interventions were on their day-to-day lives. So I think it's important for us to be humbled about it and to move forward in that direction.
Thank you for sharing. That's incredible. And thinking about, okay, I had these symptoms and I just kind of dealt with them because I thought, okay, I'm taking this drug. It's supposed to help me get better and stay undetectable. But then when you switch over, thinking of that, that's amazing. Andrew, I'm going to
Can I add
yes,
something?
Please.
I just want to give a quick example of, once again, like if, you know, an oral medication is working really well in terms of numbers for someone, what are some things that healthcare providers don't always take into consideration? So recently, at my organization, we are a site for the injectable treatment for Cabenuva. So people come, to the AIDS Committee of Ottawa and get their shot there. We have about 135 people now in Ottawa receiving their shot at ACO. So we hear a lot of stories in terms of why the injectable, for example, works, better than the oral pills, even though the oral pills, numbers-wise, are working very well for them. So one quick example, someone shared with us that the oral pill was working for them, but the oral pill was a daily reminder of the trauma that they went through in terms of how they ended up living with HIV. And once they switched to the injectable, they felt like the trauma diminished over time because they weren't reminded every single day of, like I said, how they, without going into details, how they ended up living with HIV. So those are huge things that as healthcare providers, you don't have the time or energy to really invest into to be able to see the full whole person. And then people, of course, are not going to share that stuff with you from a patient perspective unless they have that relationship of trust, or you are their support worker, or you're their therapist, or someone who takes the time to really get to know you better. So just wanted to give you an example of things that are not, the psychosocial impacts of different types of treatment that are not always considered by healthcare providers.
Absolutely. And the next question is, what are some initiatives we can each take to mitigate these challenges? And what about at the systematic level? Andrew, I'm going to go back to you.
All right. I think one of the things we often, again, don't do is question ourselves and identify our own, biases, because it takes a lot of work to do the self-work, to be vulnerable with that. And we're in a culture of health, and I talk for myself, but in our education, we learn to hide our flaws, hide our discrepancy of knowledge, and be the best, and be perfection, and to move forward in that direction. And there's this kind of hierarchy that is perpetuated and creates a lot of mental health issues in our community. But in itself, I think being vulnerable and allowing yourself to be wrong sometimes is in itself work that takes time, it takes energy, it takes commitment too. In the last year, I went to get my licensing in psychotherapy, and I was surprised to see how introspective and growing that experience was. I thought I was going to learn these techniques and learn Freudian dynamics of psychotherapy, but in the end, I learned a lot about myself and what we bring to the table when we enter these relationships with people, and how to stand back and provide more comprehensive care.
Absolutely. Heidi, what are your thoughts? And I saw a comment that just related to what we talked about yesterday, which was about listen for what patients are not telling you, which is kind of complicated because sometimes we have short time span with people, but what does that mean to you? Listen for what they're not telling you.
I think good question. I think it's so important, and it's really taking the time to read between the lines. And I know we can all sit here or wherever and say we don't have the time to do it, but those cues, those subtle messages are what is going to save lives, because those are the most challenging pieces for clients to bring up, again, depending on positions of hierarchy, relationships, etc. And so it's also about asking the questions and asking the client and truly caring about how they're doing. And so in terms of, initiatives, I think it's time to really be innovative with our approaches. We're not winning with our HIV infection rates in the country. And speaking primarily from my experience in the prairie provinces, we are in a crisis. I was recently at a national conference presenting on management of HIV in primary care for nurse practitioners, and many of those clinicians had no idea of the rates that we're experiencing. And so even when we look at research and numbers and data and all of these things that make us as clinicians feel good or not so good, depending on the data that we're seeing, we need to look at our communities, our populations, the people that we're caring for, and recognizing that not every population will fit the models of care that are happening and that are, successful in different parts of the country. So for example, Winnipeg, Manitoba as a whole, Saskatchewan, our models of care have to be different compared to Toronto, Ottawa, Montreal, Vancouver. Our methods of transmission are different. Our rates of infection in heterosexual relationships and predominantly female clients is different. And so in terms of developing our models of care, we have to, like I said, be innovative. What we're doing isn't working. And what we are doing is we're doing well. And so it's certainly not to discredit all of the hard work that is being invested by clinicians and partners and organizations, but we're still not meeting the needs of our people. So, considering other approaches, NP pharmacy models or PA NP models or whatever, it may be, and going out to the clients in the community. Expecting our population to come to us is extremely unrealistic, and we'll talk about that a little bit later on. But
yeah, and related to what you say, I see a comment that's reach outside the regular circles, right? We got to do stuff a little differently if we want to reach the people that we're not reaching.
And sorry, if I can, and allowing that to happen, right? There's such a tight hold on managing infectious disease and HIV when really, in most cases, it's fairly simple. And of course, there's complicated cases all the time, and those can be directed and referred to the specialists. But for the more simpler cases, letting go of that control and allowing other interdisciplinary models to take the lead and do the work that we are all aiming to do.
Claire, what are your thoughts? I know with a hand in the ground of the community, there's a lot of already work that's being done.
So yeah, well, I have a lot of thoughts. I think, in terms of at the systemic level, I think that, to start, there has to be an acknowledgement in terms of our healthcare system, right? In terms of the wrongs of the past. There's a long history of distrust when it comes to particularly racialized community members with the healthcare system. And we have to acknowledge that even though we are, part of this generation, and racism obviously still exists in this generation, but things that happened in the past, they are passed down in terms of intergenerational trauma, in terms of issues around trust, they're passed down from generation to generation. So even if we are seeing people from this generation, we can't assume that what was in the past is in the past, right? That distrust still exists. So as healthcare providers, just like we talk about decolonizing our workspaces and, being, really focusing our work on anti-racism and anti-oppression, I think the same needs to happen within our healthcare system for people to be able to feel really safe in having some of these conversations with their healthcare providers. So we hear about this all the time, at a community-based level. And I think the other piece that's really important to mitigate some of these challenges is, I think as a society, as a community, we need to really start thinking about decentralizing HIV care, treatment, and sexual health services to community when it makes sense. Obviously, there are some things that are very specific to our healthcare system, specific to a hospital or clinical-based setting, but things that can be done and achieved at the community level is where we should be focusing our resources. And I can say that with full confidence because at my organization, there's a lot of, in terms of sexual health clinics happening or injectable treatment programs or injectable PrEP treatment as well that's happening and the difference it makes when people are able to access it in communities. So some of the things that I talked about, whether it is about pedestalizing, doctors, whether it's about addressing racism, whether it's about people being given the time to really be seen as a holistic person with many different dimensions to them around housing and food security and immigration and employment, not just CD4 counts and viral loads. That really happens at a community level, because at the community level we do have the time, right, the mandate, the people that we are to be able to connect with people in that way. And particularly when you get peer support as somebody living with HIV and being able to connect with someone else who has a lot more experience living with HIV than you. So those are some, a few of the things that I would like to mention in terms of mitigating the challenges and addressing things at a systemic level.
Absolutely, thank you. And just reading some of your comments, I see clinicians should think about their own anxieties as barriers, whether that be injectables or supporting chest feeding. We need to be honest with clinicians' anxieties, and talking about options can create barriers. Anti-racism training for all healthcare workers, person-centered approach, a lot of participating in anti-bias training, a lot of great comments about like an update on research and an update on things, and just keeping up with like lived experiences to understand like what the new options are and making sure that's expanding our education. Jonathan, I'll hand it back to you.
So just, to almost a segue to a next section and some of the work that's being done, but to highlight both care of the individual and the healthcare system, what's important is expectations, that expectations are realistic. If someone comes in, regardless of the setting, and expectations are not realistic, they'll be disappointed, and the people taking care of them will be disappointed. So it's important to understand the limitations of the individual physician perhaps taking care of you, or the medical system around you. So that's important to understand. To understand, and to that, there's been work done, including by some folks in this country, about patient-reported outcome measures, and that's so this can really potentially help streamline patient care and address some of the issues that are being discussed here. So there are guidelines recommending the use of patient-reported outcome measures, tools to enhance communication between healthcare providers and people with HIV, raise awareness of health status for both, promote patient-centered care, and empower patients in their health discussions. So if you're using this, if you're using a tool, if you have time to use a tool, even if you say your immediate response to your healthcare provider is "I'm fine," by using this tool, things will come up, like the answers to the questions that you haven't asked, right? That's you may not be able to read your patient very well. You may think there's something there, but using these tools may be a way to bring those out. And there's some that are happening, that have been developed in Canada. So the first one, iScore, I think Bertrand Leboucher in Montreal has been key behind developing that one. And the MyPro, which is in Toronto, there's a poster. Maybe you can read the poster number, but it's presented here at CAHR. So this is another tool that can perhaps help the communication or relationship between the physician and their patient or client.
Thank you, Jonathan. Our next question is, how can healthcare providers still empower patients and clients if they aren't eligible for an option and their choice is more restricted? Claude, what are your thoughts?
Well, I think, even if they're not eligible for a particular option and their choice is more restricted, I think one of the ways the healthcare provider can empower the patient is by making warm referrals to places where folks can, once again, access services that are not provided by the healthcare providers. So I know a lot of folks, the primary reason why they walk in through our doors is not specific to HIV treatment. Sometimes it is, but a lot of times it isn't. It is really about affordable housing. It's really about, immigration challenges, food security, employment, mental health. So I think even if their treatment options are limited by the healthcare provider, but if there are other social determinants of health where they can be supported around, it will greatly benefit living with HIV, even if their options are limited in terms of treatment. So I think having that relationship, I know in Ottawa, I can use Ottawa as an example. I feel in Ottawa we're pretty blessed. We have pretty awesome relationships with our public health unit, with Module G, where Jonathan works and other places that offer HIV medical care. So we're able to very easily support people in navigating the systems in Ottawa because of these relationships. So I think that's also one way that we can empower folks is by having these relationships with each other so that people don't face barriers when they're going, for different reasons to different places. Yes. So sometimes we don't think about our relationships improving and being better established as benefiting the patients themselves. But that's, I think a great way of looking at it. And I think, honestly, like Ottawa would be an example. I hope you feel that. I don't want to speak on behalf of you, Johnson, and your team at Module G, or I think Dr. Patrick O'Byrne is probably somewhere in the crowd here, Dr. Jason Brophy from CHIO, like in Ottawa. So I think a lot of you can attest that we have a pretty good thing. It's not perfect, but we have a pretty good thing going in Ottawa in terms of empowering patients through the relationships that we have with each other.
Yeah.
So I hope that makes sense.
I think, Jonathan, you mentioned also like being aware and also having expectations and knowing what that is. And for me, I don't feel like my healthcare provider needs to empower me. I'm not expecting that. I get my empowerment from my friends, from some of my family. Like that's where I need it. But I need you to inform me. And I had, many years ago when I was part of an ad board, like a community ad board about the injectable treatment, I went to my doctor. I actually scheduled an appointment, and he immediately came in and was like, I already know what you're going to ask me, and it's a no. Like you can't have it. It was just that. And it was just like, okay, just shut me down. I was like, people don't tell me no. Yeah. I was like, what does that mean? And it wasn't until like years later that I fully learned like about resistance, and that when I was a child, I got resistant to, what's that one medication?
Rilpivirine?
Yes, that girl. I was resistant to her like a while ago, and I didn't understand that resistance and why, okay, that's not eligible for you in the treatment option. And I think in that way, that was just disempowerment, and it's like, just inform me, educate me in that, and why I understand we all have different time frames and things like that. Just shutting it down was kind of like, okay, what did I do wrong, and what is that? And I think that's when in community, and that's why I see a collaboration where it's like, okay, if the AIDS service organizations have that education and can provide that, how could we collaborate where we're making sure we're getting that information and still understanding that, hey, this option isn't eligible for you because you are resistant. There can be options down the line. We don't know what's going to happen, but still empowering that it's not like, hey, let's just give up. That's available for others, but not for you.
Yeah.
Understanding.
Well said.
So I just want to add very quickly. I know you're talking about medications, but it's not just medications when there's questions for your physician, right, when it comes to your care. I think people should ideally feel comfortable to ask questions, have the opportunity to ask questions, feel like they have the time to ask questions, even though they might not feel like they have time for questions. But it might not just be about your medications. I mean, you could ask, do I have to come every 6 months? Can I come every year? Do I need this blood work done? You do this blood work on me every year because it's your routine. Do I really need to have that done? I know you have clinics. I come Tuesday. Can I come in the evening, the afternoon, or on the weekend? I mean, you should be in an environment or a relationship where you feel comfortable asking the questions. You may not get the answers you want to hear, right? Whether it's the therapy or some other thing, you should feel comfortable, ideally, asking those questions.
And I think as healthcare providers, we should feel comfortable saying that this is not possible, this is not accessible yet, and not shutting that door immediately. One of the things that I feel like sometimes we were talking about time and time restrictions, and sometimes we want to do so much in so small of a time. But one of the things to think about is like working less in silos and working with other people. And we were talking yesterday at dinner about working with peers, and we rose the fact that in Montreal perhaps like we don't work with peers enough, and we do have psychosocial services when they're available, and when like the system provides us with some at the clinic, which is helpful. But sometimes it takes more than that one social worker that takes on like the thousands of patients of each clinic to kind of navigate the resources and the things that are really wonderful that are happening in the community out there. So I think a matter of, I was saying like, I'm a strong advocate of it takes a village to heal. Well, this is an example of where we can do better.
Yes, and Andrew, I see a comment on that. First and foremost, we need to empower ourselves, meaning healthcare providers, so we can empower for our patients. We must show dedication and commitment to what we do, and we need like that call to action. And I think that that's really important as well, because it's like service providers also get burnt out or also feel that frustration if something is not available and things like that. And so it's also thinking about, okay, empowering ourselves as healthcare providers in order to be able to empower patients.
Yeah, can I just add? One of the questions from earlier this morning to the presenter was, you know, we're all chasing the same funding, and there's limited funding, and some goes here, some goes there, and so it's similar to this in terms of like working in silos. We should be working collaboratively, really from coast to coast, and irregardless of our patient demographics and populations. I mean, the goal is the same in terms of HIV care management, prevention, and all of that, right? And so it's even within our own provinces, sometimes there's, they do one thing and we do another, and it shouldn't be like that necessarily, because we often share the same clients, and again, the outcomes that we're hoping for are all the same. So empowering, as someone mentioned in the audience, you know, empowering ourselves is really important, and I think we often don't credit that enough. And then for the question of eligibility for clients, you know, things are always changing. There's always new products coming. Sometimes funding takes a little bit longer, but acknowledging that with the client, and building awareness of, well, it's not being publicly funded yet, but you know what, as soon as it is, I will make sure to call you, and just, you know, kind of giving them that little bit of hope and information, so that it's something that may be an option down the road for them.
Absolutely.
Muluba, can I add something? Just in response to what you're saying, Heidi, in terms of things being more standardized across the country, and right, things are very haphazard, and you know, varies from province to province and geography to geography. It would be incredible if we did have, if our federal government, for example, had a national strategy in addressing HIV and STBBIs, but at least in Ontario, we do have a HIV action plan. I don't know if everybody in the room is aware or not. I hope everyone is, given that you're at the CAHR conference, but in case you're not, there is an actual action plan that takes us to 2030, and this action plan looks at a lot of the dimensions that we have been talking about. That's not just about the medical model in when it comes to HIV. It looks at, you know, our healthcare system, issues around, you know, racism and trust, and various different social determinants of health, and how they're equally important in addressing and eliminating HIV someday. So I encourage everyone, if you haven't seen it, please look it up. It's available online. It's the Ontario HIV/AIDS Action Plan to 2030. And that, I just thought of that as you're saying, talking, Heidi, that, you know, things should be more level and standardized regardless of geography and what part of the country.
Yeah. That would be the goal, right? Yeah, that all the provinces would be that communication. Our next question is, how does structured presentation of all options, including long-acting options, optimize informed decision-making? Jonathan?
So I think the idea of a structured presentation is a fairly new one. I'll let Andrew speak to this a little more when it comes to prevention, because it really is shown and used in the setting of prevention. In the setting of treatment, I'm not familiar with any work in this, and I'm not sure it really fits, because every situation is different. Physicians are different, patients are different, their clinical history, their personality. So I'm not familiar with how this would really enter into discussing treatment options, because I think that has to be a little more tailored. That's just my sense, and it's not something I'm familiar with, a structured presentation. But I mean, Andrew, I think is going to speak on this, the work that's been done in the setting of prevention and PrEP.
Are there any thoughts on with the?
Well, the next slide is about the search study, but there is a positive shift, I think, in perspectives in terms of allowing patients to advocate for themselves, really, and to kind of have a voice in expressing what their preference is at the current time, and if it's possible to be a partner in that decision making. So this search study took a group of people, and interestingly enough, the participants came from Eastern Africa. 73% of them were women, which we are seeing more and more in the studies, which is encouraging. But I think there's even progress to be made for injectable drug users and all that. 30% of the group were people between 15 and 24 years old. And they compared two groups. So a group where HIV prevention was provided with dynamic choice in the sense of whether they wanted long-acting or oral PrEP or PEP, and the ability to be switching from one to the other, or to stop, or so to be self-determinant in their prevention treatment versus standard of care oral PrEP or PEP. And there were 0 participants who acquired HIV in the dynamic choice group versus 8 in the standard of care group. And within the group, 56% chose long-acting options. And within that 56%, 42% of these participants weren't exposed to PEP or PrEP recently. So it comes to show that there is the possibility of expanding to even new users, of people who aren't exposed to PrEP and PEP, which is interesting enough because we're having a further outreach. And if we modelize this over the next 10 years, there's a model that shows that it might be possible to reduce by 1/3 the incidence of HIV in Africa if we're allowing more structured, long-acting, choice-based prevention of HIV. Needless to say, it comes in a time where fundings are being cut in these countries as well. So I think it's very interesting to see that it's not because we're driving away from our standard of care, our unquestioned status quo, that we might not result in maybe better outcomes. There were similar data for MSM in Brazil that showed the same kind of statistics, and I think that's really powerful to think that if we're being more partnered, less of a patriarchal model, then we can perhaps even have better adherence and outcomes than we do actually.
And I saw a really great comment, actually 2 comments that I want to point out. Someone said, when all options, including long-acting injectables, are presented in a systematic and consistent way, it reduces the risk of bias, omission, or assumptions about what a patient needs or they can handle. Everyone gets the same baseline of knowledge, regardless of their identity, background, or perceived readiness. And the result is people are less likely to be steered away from options based on a provider's assumptions or systematic inequities. And someone else noticed, when a patient is informed and happy with their plan of care, their chance of adherence and retention is higher. And you're speaking about that, right?
100%, yes, I agree.
So now let's look through the eyes of the patient and community. We're going to discuss choices in HIV treatment and prevention. So our scenario is, at a healthcare visit, a patient asks if there are any other regimen options. The healthcare provider shares the other options available and explains why the person may not be eligible for certain ones at this time. From the patient perspective, why is it important to discuss all the options? Glad, what are your thoughts?
Yeah, well, I think it's very straightforward. I think that people should have access to all the options. It is it's their basic human right. It's their basic health right to know. So even if they're not eligible for a particular option, I think all options should be provided to them, so then they can feel empowered to decide for themselves, how they want to move forward. So I think that once again, I think that this piece for healthcare providers is absolutely essential, because I know we're talking about time limitations and time restrictions for healthcare providers, but I feel like this one in particular is something that all healthcare providers should invest a lot of time and energy into.
Yeah, and I'm sure you know from the executive director of an ASO, if you don't discuss the options with your healthcare provider, eventually you will learn about these options within the community. We still talk, we have kind of those conversations. Yeah. So it's like, it's gonna happen at some point, and you hopefully would want it to happen directly with your healthcare provider, whether or not, right, you're eligible. Heidi, what are your thoughts?
Yeah, I agree. Like I have clients who come in all the time who are like, oh, I heard about the HIV needle, you know, and so then it's, then they heard from the community, and so then we have a conversation about that. But Again, I echo what you say, and I think my general approach with clients is I tell them that my job is to present them with the information, the evidence, in a way that they will understand, and that they are the ones that are going to decide. I'm presenting them with, information that is safe for them based on their labs, based on their personal situation, not structured approaches. I don't think we need any more structured approaches. It really needs to be tailored to the individual. And so I get a really good response from my clients when I say that to them. They kind of like look at me sideways and are like, oh, okay, like I have a say here. It's like, yeah, you absolutely do. Like, this is a partnership. We are partners. I am not here to tell you what you are going to do or put into your body. You are going to make that decision with the knowledge and information that I share with you. And even if something isn't, if they're not eligible for something, I also have that conversation as to the why. Yeah. Because again, it is their right to know. So again, just involving the client in that discussion and really viewing it from a partnership standpoint. And just changing.
Sorry, Andrew, just like when Muluba was saying that people talk in community, I think going back to the piece about trust, and this is really important, like especially for you prescribers, is that if folks find out that Jonathan didn't tell me these options, and then Colette at ACO is telling me that there is a thing called Cabinova, and like it will not generate trust in the future. So if we're going to overcome this barrier of patient, clients, healthcare system, and this huge issue of distrust, if you're not discussing the options, like Muluba said, people find out in the community at some point. Somebody will be like, hey, did you hear about this? I'm on this, or so-and-so is on this. And they're like, what the F? Like, Jonathan didn't even tell me something existed that I could take every 2 months, right? So please remember that the trust piece will only diminish if all options are not discussed. Sorry to
No, absolutely. There was just a comment on our Slido that it helps maintain trust with the healthcare provider. We're living in an age where information can be easily accessed online, so a patient can learn about the options and then lose trust in their healthcare provider. So now we're going to go to the healthcare provider.
Yeah, oh, that's neat.
Jonathan?
So when Cabinova been out for a little while now, when it was first brought out, there was questions whether they came from Vive or others, like identifying the patient or the client that would benefit from it. And that I think guided some people some ways, and I happen to have a fair bit of experience with, and I don't think you can identify a person who's best for this. I think I've learned that I cannot predict who would want to be on Cabinova. I have physician colleagues who said, I know which one of my patients would. I tell them they're wrong. They don't know, and that's only come with time and experience. I mean, I may have thought that initially, but over time I've realized I cannot predict who will want it, who won't. So that's my habit is to discuss it with everybody at least once. And then colleagues who have started to prescribe it have, I'm just tooting my, blowing my own horn now. They come back to me and said, you know what, you're absolutely right. I can't predict who's going to want it. And unless you raise it, you have no idea who's going to want it. You may think that this person wants it because of stigma or travel or confidentiality or whatever, but you don't know, and it's all walks of life that would prefer, and there's people that you think would jump on the bandwagon that say absolutely not, and it's
they're
so
like committed to their pill every day.
Yeah. I want to share my personal experience with PrEP. I've been on oral PrEP for years, and I went from daily PrEP to like on-demand PrEP to like forgetting my PrEP to like, oh, I didn't go to the pharmacy to refill it, so oh, did I take it? I'm going to take a second one, and then having all my side effects. And when long-acting options came out, I'm like, okay, I'm going to test myself as a guinea pig, and that's what my clinic also did. So I took, so the first shot I had was, I probably had gastro at the same time, so I had all these symptoms that I'm like, is this a virus? Is this side effects? Why was I informed? And I came to a place where I'm like, well, I'm very privileged to have all this information, these new studies that are at hand and thrown at me, and I'm just absorbing the knowledge. And even then, as someone that is experimenting the use of a novel tool for it themselves, I'm still in the works of that. And then the second dose came, and it was fine. So it allowed me to go into that process of self-reflection and gave me a position of where I felt, empowered in my decision, where I had this information and I tested it for myself, and my colleagues were reassured afterwards. But I think I know that I come from, a privilege of knowledge, and sometimes if we don't allow that privilege to our patients, then how are they supposed to make choices for themselves? And this is what my reflection came to.
Absolutely, thank you.
One of the things I appreciated about my doctor is he's on top of things, so he's coming to me with the latest information, and I'm someone who has Google alerts set up for anything HIV related. So I can make the best decisions for myself with the help of him or whatever doctor. And I think that's just a very important piece of the puzzle, is no two people are the same.
To make this person who is HIV positive to have a decision for her medication. Not just the doctor to decide to say, this is good for you, but to give opportunity.
Not only do I have HIV, but I am also a descendant of residential and day school survivors, and everything that has happened throughout the years and the generations and the traumas involved and the addictions that are linked, the unhealthy approaches to different things. I am going to make first and foremost my mental health, my emotional health priority.
I need to see everything if it's appropriate for my metabolism, for my body, for everything.
As a peer, help folks, or teach folks, I guess, how to advocate for themselves in a healthcare setting. I'm a firm believer that no one is more of an expert on my HIV than me. But that's the ideal situation, being able to, talk to your doctor about what your needs are, and more so having your doctor actually listen to you.
That was so important for us to show, because we realized we can't represent all communities here on this stage, and also just having a few people share their perspective, but also seeing in your comments that it comes, a lot of people said, my body, my HIV, like my choice. Somebody else said it also shows that like there is that trust also in the patient. There is that respect when you're showing me all those options. And so I think our next, how do we empower patients to take control of their health? I'm very, I wonder with this because, and I wondered about this question and pondered, like, take control of their health is, I already have control over my health. It's still my body. I mean, I have my HIV, it's not 9 to 5, it's actually 24 hours a day. My health is my health, and I still have that control. It's what I do with that control. So it's not even that we need to take control. It's actually, being really respectful with your own body and like really taking that control and being eligible of that. And there's so many limitations to the system. I know when I book appointments with my family doctor online, it like says 10 a.m., 10:10, 10:20, and I'm like, you are my general practitioner. We are going to talk for a half an hour. Like, what is this online? And then they say in the box, what is your one issue, that you want to talk about today? And it's like, that's already a limitation. But we all do play a role in that, and I understand also with timing. And I think same applies to PrEP. I always, now with the long-acting PrEP, I think, I guess for somebody that's not living with HIV, maybe that would be something that's more accessible, or that you would want to go for an injection once a month or once every other month. And so I think that empowering, I guess, is informing them to take control of their health. And I think a lot of we do that as peer work, talking to my friends and my peers and even my colleagues, and that, oh, you didn't know about this, or how do you, advocate for that? And I think it was somebody mentioned, like, we advocate better sometimes for our friends than we do for ourselves. Like, if I'm going to an appointment with my friend, I'll be like, what is this? This is the questions. But if my anemia is down and I'm feeling weak, I don't have the energy. I'm not the Muluba standing here. I don't have the energy to even fight with my healthcare provider. But then look at that. My first instinct is fight with my healthcare provider. We're not fighting. We're on the same page here. They want me to live as well. But then I think that's also the thoughts that go on. Khaled, see you nodding and agreeing. What are your perspectives?
Yeah, I agree with everything you said, Muluba. I think in terms of people taking control of their health, of course, on the surface, having accessible information, first of all, and by accessible I mean being able to overcome language barriers. A lot of folks, the information may be there, but it's not in an accessible form for them. And then, of course, in terms of treatment, whether it be prevention or treatment of HIV, having it affordable as well, so that people are actually able to pay for it in some capacity. But that's more surface stuff. I think in order for people to be able to take control of their health, a lot of different things kind of have to come together. I think everyone for the most part, I think, would want to have some level of control over their health if things were in place. So often, and I know, like in cultures like where I'm from, for example, right? Folks are always prioritizing other people in their life, whether it be your, parents, taking care of your parents, or taking care of your children. Lots of single parents taking care of like multiple kids, right? So it's not so much that they don't want to have control over their health as much as that, they prioritize other people's health. So that's why I've been stressing a lot today in terms of looking at the whole person. And a big part of us providing HIV care and HIV treatment is looking at all those other dimensions as well. So if somebody is really struggling taking care of 4 kids, is a new immigrant, here in Canada, their health is probably not going to be, their own health is probably not going to be their number one priority, right? So how are we supporting them with their immigration status? How are we supporting them, in terms of food security for their kids? I think if those things are in place better, then I think people would make better choices about their own health. And sometimes we don't always look at all those deeper angles in terms of people's health. So I agree with everything you said. So on top of that, I wanted to add that, Muluba.
Thank you.
I want to add a little quirky thing, but sometimes it goes beyond like treatment discussions. I think when I have a new diagnosis and they're shocked, and I'm like, go get a credit card with travel points and put all your antivirals on it, and then it'll like fund one trip a year for you. And I read a concept called the least disruptive medical interventions, and it all goes with like how to lessen the pill burden and simplifying treatment and make it less of this burden that they have to carry and this stigma that they have to carry, and how to make it kind of positive in the sense to kind of like uplift their quality of life despite a bad news or hard decisions to make. So I think this is
things beyond HIV or prevention. Yeah, absolutely. And now we're going to go through the eyes of the public health.
Before we jump to that, can I just add super quickly that taking control of your health can also be very shaming. Because certain people, depending on the lifestyle that they live and the state of their health, it can be very correlated to some of their choices and or not necessarily choices, but their ways of living. And so I think we really have to be careful when we have those discussions, because people know, right? Let's say people who are using substances, they know that they shouldn't be using substances. They know it's bad. They know it's, or a diabetic who's eating a cheesecake. Like, they know they shouldn't be doing this, but they still do it. And so just being really mindful of how we're approaching those discussions is super important, to not shame people, and then to establish realistic expectations on how, okay, this is what's happening in your life, and establishing the plan of care from that point forward. But yes, through the eyes of the public health. Thank you so much. So we had all agreed on this quote here from the WHO, and then as I reread it over and over, I was kind of like, I don't love it anymore, but I will read it and we'll chat about it. So health systems should invest in people-centered practices and communication, including ongoing training, mentoring, supportive supervision, and monitoring of health workers to improve the relationships between patients and healthcare providers. So the wording ideally is great, but what does that mean and how do we actually do this? And so people-centered care, this has come up numerous times, even in our brief discussion today, but also, we've all learned about this in school and congresses, conferences, ongoing learning, that we should be people-centric. But what does that actually mean? And do we truly practice this? How many times have we documented the client no-showed, the client was not adherent, the client refused, the client did not, etc.? Do we follow these statements in our chart notes with a why? Do we actually ask our clients why they didn't take their medication, why they didn't attend their appointment, why they didn't go for that CT scan? Or do we just assume that it's some form of delinquency or that they're not interested in their health care, which may then further negatively impact our relationship with our clients, further creating that bias and those unhealthy patterns. For many clients that I work with, if they don't show up, my first thought is, I hope they're okay. My second thought is, I hope they're still alive. So that is the population that I work with. When they do present, a lot of times much on their own schedules, so scheduling appointments for many of my folks is just not realistic. And so again, another kind of innovative and out-of-the-box thinking that we sometimes have to approach is being more accessible, same-day access models of care versus stringent scheduling. And they attend their appointments for things that are prioritized for them, and it may not be related to their HIV or their HIV prevention. When they attend, it's often for shelter, it's for safety, it's for food because they're starving. Many of my clients use substances, particularly meth, because it's the most accessible and the most affordable. And we often have perceived biases of these people who are using substances. But I can tell you right now, and question actually, have you ever asked your client why they use substances? And the most common responses that I get are, they use meth to stay awake at night because they don't have a safe space to lay and rest. They use meth to avoid being physically assaulted, sexually assaulted, exploited, abducted, or killed. So again, when we're talking person-centered care, these are all things that are extremely important to ask and consider. Their reality is often our worst nightmare. Their worst nightmare is not their HIV or the risk of acquiring it. Yet we expect our very vulnerable, our marginalized, our racialized, and our traumatized population to adhere to our norms, our expectations, and to fit into this tiny box of conformity. So I ask, I question, and I challenge as we have this conversation and as we all move on to our lives, are we actually practicing person-centered care? And how can we better this?
Absolutely. Thank you, Heidi. Question for all of you. What are our major public health challenges, and how can we start to broach some of these challenges? Colette?
So, I think the major ones I've already, talked about, Muluba. I think that the trust piece, I think, is really huge and should never be underestimated. So I think, in terms of public health and our healthcare system, I really think that we need to start really rethinking and revamping the way we approach things. and really focus on, how we can start the rebuilding process, or if we are there, depending on where you work, how we can keep building on it. I obviously, discussed some of the stuff earlier. I think in Ottawa in particular, we have a good model of how to do that. And I have to go soon, so I just want to give an example of the public health challenges and how we can broach it. So very quickly, just as a model. So in Ottawa, in 2021, when the COVID vaccines were rolling out, we decided to partner with Ottawa Public Health and a local clinic called the Moderator Clinic to make the first dose of the vaccine accessible to people who need it the most, like vulnerable, marginalized, racialized community members. So we decided that we have to leverage each other's strengths. So obviously, public health and the Moderator Clinic, they're responsible for the clinical aspect of the vaccine, and our role was to reduce some of the barriers like booking an appointment, navigating that crazy, difficult booking system that you all probably remember, reducing language barriers, having staff that can translate for people who are coming to the clinic, providing childcare, providing transportation. But one of the things we did too around the trust piece is that we talked to people about it ahead of time, and then we took the vaccine ourselves. A lot of our staff team members, they represent the communities that I'm talking about. So they're either Black or brown or living with HIV or use drugs or whoever the priority populations are. So when people saw that, we were taking the vaccines ourselves, they were more likely to take it. We were the ones who welcomed them when they came to the clinic. I can go on and on, but the point I'm trying to make is that I think when clinical-based settings and community-based organizations and settings work in partnership together and recognize each other's strengths and leverage those strengths, those are one of the ways that we can, overcome some of these public health challenges. And we ended up, the first dose clinic, we ended up vaccinating over 500 racialized community members in Ottawa. But that's just an example of some ways we can work on that, versus doing the silo stuff that we do, that Jonathan works in his office, I work in my office, I have no idea who he is, he has no idea who I am, so that's what, I wanted to leave people with. And the last thing I always say is about that at the end of the day, folks, we're in the relationship building business. So let's start building relationships with each other if we're not doing it in our communities already, because I hear horror stories from my colleagues across the province in terms of their relationship with their public health unit or some of their, HIV specialists. So if we're gonna do this right, we need to build these relationships with each other, and ultimately, it is the patients, the clients that we're saying in this session, our community members, that benefit from building these relationships with each other.
Right.
So I'm glad.
And we know in community, public health does not, they have the worst public relations department. They don't have a good, yes, right. Even
100%.
when you talk to the community and stuff, it's like public, why is my health public? Why are they involved? What is it, knowing the history? Andrew, you also talked about like working in silos, and that's something that we need to break.
And I find it interesting, the quote that was posted before, because we're talking about patient-centric care, but the quote is focused on how to better healthcare. So it's very healthcare provider-centric. So if you look back, it's kind of contradicting itself in certain senses. And that kind of shows our own biases, like how the bridges that we create unknowingly, and how do we just like build that bridge and kind of move forward together. I think that's some of the things that we try to have all these ingenious and innovative ways to kind of switch it up and find ways, but sometimes it's just a matter of like observing what we're doing and identifying what we're doing that can be better and moving forward in the same direction, because again, we're all trying to reach the same outcomes and goals and cohesiveness.
It's constantly observing what we're doing and evaluating what we're doing, what's working. Jonathan, is there one major public health challenge?
I don't think so. I think it's very regional, and if even just regional, it's local. And the public health challenges in Ottawa and in central Ottawa are very different than the public health challenges in the community. Public health has have raised some issues regarding, not specifically, but about public health, the provision. And our experience with public health is very varied. Some is outstanding. Like some of the provision within Ottawa, public health care they provide is outstanding. They have their own challenges. The folks I know that work in public health in Ottawa want to do more and want to do better, but they're limited by the structures that exist. Where we are, in many places, the PrEP is prescribed at a tertiary care center, right, at a hospital, which is not conducive for the care of healthy individuals that need preventative therapy. That's not the best place to provide that care. It's probably best provided at whether it's a public health clinic or a community center or by nurses of whatever type whatever healthcare professional on the outside. But it's not. But that happens out of necessity because so far it's not. The public health folks have not been able to provide that care, and I think they want to. I think they'd like to, and I know you met Patrick Coburn and Lauren Orser in Ottawa who've really done a lot to that, but they're limited by what the structures with which they work to be able to do that. So, which is very different than public health issues in the prairie.
Yes,
I was just going to say, I don't know if anyone is here from public health in Manitoba. If you are, I apologize. I don't even know if public health exists in Manitoba right now. So that's how well it's going in our area of the country.
Well, let's look through all our eyes. So I'm going to ask all my panelists first. What's your call to action? We've had this discussion. Colette?
My call to action is, just basically what I said earlier. It's about building relationships with each other.
Mm-hmm.
And
I like what you said. We're in the relationship building business.
Yes,
I'm
exactly. Well, I always tell everybody, my staff team, volunteers, whoever I work with, is that on the surface, obviously, we're in sexual health and we address HIV and STIs, but at the root of it, right, we build relationships.
Mm-hmm.
And that's what makes us and our sector different, right, is that everything we do thrives because of the relationships we build with each other.
Yes.
So my call to action is that in terms of clinical, hospital, HCPs, and community workers, that we really focus on building that relationship with each other so that our community members can ultimately benefit from it. So.
Absolutely. And I think there's so much going on in Ottawa, and then I guess Ontario wider as a province, like we're building those relationships, but also those barriers of like the province, and we just separate. Heidi, your call to action?
Yeah, thank you. My call to action is, it's not about us. It is no longer about us as healthcare professionals. It's about the clients and truly putting them at the center of their individualized care, and being innovative in terms of healthcare delivery models so that we can reach our clients to provide the care. Expecting them to come to us is no longer realistic for many, and remembering that there's whole provinces outside of our major cities, right? And so care is significantly lacking there. So essentially just being open to interdisciplinary models of care to do the same work, the same quality of work, and working collaboratively towards the same goal.
Absolutely. Thank you. Jonathan, what's your call to action?
To quote a great mind, relationship building.
We're original, organic.
Relationship building. So I'm not sure I have a specific call to action. I think there's lots of things that can and need to be done. Though many of these are real challenges. One is empowering early, facilitating the patient or client to look out for what's best for them, but also have physicians provide that opportunity, that environment that facilitates that allows that. I think with the availability of long-acting injectable therapies, I've learned a lot about kind of behavior of my treating colleagues. It's interesting. It's a learning experience, but also about our patients and what they will or what they won't ask about. So it's learning. It's a big change, right? For 25 or whatever years, it's only been pills. There's been no other options, and it's just a change in how care is provided, and different people respond very differently. So it's just interesting to learn, but so it's both sides, right? It's a relationship, but it's having patients comfortable asking questions, having physicians open to discussion and open to responding.
Being open to change.
Yeah.
Andrew, finally, what's your call to action?
Well, to piggyback on all of these wonderful people, I think my call to action would be to do the work, the self-work, to stay humble, because again, it's not about us. To reassess periodically. I think we do it once and then it's in the attic and we don't redo it, then it's not worth the time that we invest in it. I think it takes courage to go there for patients and for healthcare, and to do it beyond our own individual, to go in our groups, to go in our systems, and to dare to break free from, all these things that tie us down unknowingly. Work with partners and trust your partners, your peers. Sign those collective prescriptions with your pharmacy. They can also assess renal function and HIV tests. Delegate. We're not alone, and I don't think we should be working alone in all of this, because it's a community-based practice and necessity.
Absolutely. And just on that, we do, I know, we want to hear from you and all your calls to action, but before that, Khaled is doing great work and needs to leave right away for our flight. So I do want to thank Khaled so much for being a great panelist, and thank all my panelists, Jonathan, Heidi, Khaled, Andrew, for joining us today. Weren't they amazing? Give it up.
Thank you, Muluba.
And Khaled, you can now storm the stage and leave like Beyonce. Just stroll down, give us a little more. Make sure you give back the mic. Yes. They charge us for that if you take it to the airport.
We'll hear you when you leave.
Yes, we'll be able to hear you in the airport. Thank you all so much. And now we want to hear from you. What's your call to action? I'm seeing some in the Slido, but we do have 2 microphones. And if you want to say your call to action, or if you have any questions for myself and my panelists, please feel free to ask them. I'm seeing some calls to action, more funding. That's always a huge thing. We need more money. Money does not pay for happiness, but it pays for the pursuit. As they say, combine new research options with research progresses. HIV cure, that's a great call to action. Wouldn't that just solve almost everything, the HIV cure? Really valuing the individuals and their unique perspectives to provide best personalized care. And having that end goal of ending HIV. Any other calls to actions? All right. Thank you so much, everyone, for being here. We are delighted to have you. And again, thank you for ViiV for supporting us. And thank you for Liv for organizing this. Thank you so much. We hope this was a great presentation. Please. Hello? Is the mic still on? Hello? Hello? Oh, hello, hello. Lastly, also on Slido, there is an evaluation form. It really helps us out for what we provide to you next year. There also is on your table. We would really appreciate if you could quickly do the evaluation. Thank you so much. Bye.